Good evening, everyone. It's a pleasure to join you on this very last episode of Ask Your Doctor for the year. I'm joined this evening by Dr. Raúl Olivares from Barcelona IVF and Dr. Harry Karpouzis from Pelargos IVF in Athens. Thank you very much for joining me, both of you, this evening. We're going to talk this evening about recurrent pregnancy loss, and we hope that this will be very insightful, and I hope to answer some of your questions. So if you have any questions, you can the chat box, and we'll try and get through as well. My name is Shabana Bora. I'm a consultant gynaecologist and fertility specialist based in London, and I am a co-founder of a small independent fertility clinic based in South London. So thank you very much for joining today. So I'm going to start by posing myself as being a patient. So I'm a patient, and I would like to understand, having had 2 miscarriages before, how I can prevent a further pregnancy loss, and in particular looking at having IVF. So shall I open the question to Dr. Raúl?
Mm-hmm. Well, recurrent miscarriages is always a tough issue because most of the time the only thing that we can do is transfer good embryos, and then whatever happens later is very difficult. I would say that we usually focus on the embryo quality, and when someone has recurrent miscarriages, I think that the main thing that we can do is try to confirm that the embryos are not just pretty but also genetically normal. Most of the miscarriages are related to genetic issues, so PGT becomes an essential tool to confirm that those embryos, especially when the patients have, I would say probably over 38, is when the percentage of abnormal embryos starts becoming important. You should transfer embryos that have been genetically tested, and that will be my first approach to any kind of recurrent miscarriage.
And what would you say, therefore, that so when all of us have a different definition for recurrent miscarriage? So previously it was always deemed 3 consecutive miscarriages, and would you agree with that definition, or would you start investigating someone after 2?
I would say that probably in our case it's a bit more age related. Probably the patient is younger. It's hard to understand why a 33 years old girl may have recurrent miscarriages than not a 43. Okay, so probably we could be more tolerant with patients that are slightly older, but then when they start, we usually recommend in young patients, well, probably after 2 miscarriages, if you are 34, 35, and there's nothing else, probably you should start looking if there is anything wrong.
Okay, so then Harry, would you say, if I was a patient coming to your clinic, how would you counsel me in terms of, for me to try to understand the causes for recurrent pregnancy loss?
Okay, the most common reason of recurrent miscarriages is always chromosomes. The chromosomes can be related to the age of the woman, but not always. Even young women can have embryos that are not chromosomically normal. So the first thing is to determine if we are talking really about recurrent miscarriages. As Raúl said, when the woman is young, which is getting more unexplained, we start investigating about 2 miscarriages as well. And the main thing is if we jump to IVF, and if we need to jump to IVF, always it's PGT-A, because if we don't transfer an embryo that we don't know the chromosomes of, and it fails again or it miscarries again, we will not know what exactly is the reason. And then there are other reasons, of course, other reasons that have to do with the uterus, with the womb, septums, polyps, fibroids, all these things. You can see them, for example, with an ultrasound, but many times you need to do a hysteroscopy to identify these issues. Chronic infections can play a role, and it's becoming more common, and there are relevant tests now that have to do with that. Always we need to test about blood clotting, about immunity, like thyroid tests and other more rare conditions. Many different factors, but it starts everything with the chromosome. So this is the main thing that we need to rule out before we start investigating more rare conditions.
Okay, and do you routinely check both male and female karyotype, or are you talking specifically about taking the patient through IVF and then going straight into PGT-A without checking a karyotype?
No, always we need to check the karyotypes before PGT-A, because the PGT-A, if we are missing something about the karyotypes, cannot be accurate as well, and the thing is legal. So karyotyping is the first thing, because you need to rule out some translocations or anything else, and you need to know if you will do PGT-SR or PGT-A, depending on the case. But the first thing is a karyotype for both of the man and the woman, for the couple.
And that's interesting. Raúl, do you also check karyotype in everybody having a PGT-A cycle?
No, in all patients having IVF, not PGT-A, because sometimes when you do the karyotype, you find out that the reason of the failures is the genetic issues, and then you would have to add PGT to a group of people that may not need it initially. And even we also are quite fond of checking the genetics of the sperm. You know, we have a lot of experience doing FISH to try to find out if the percentage of sperm carrying chromosomical abnormalities. That's quite interesting, especially when you have long-standing infertilities or recurrent miscarriages in which everything else is normal and the girl is young. And sometimes the problem is related to the semen, not to the egg. It's much more common in patients with a severe malfactor, but we have patients with a normal spermiogram that also have abnormal FISH or DNA fragmentation. Really high levels of DNA fragmentation may also increase the miscarriage rate. And you focus everything on the egg, you know, always blaming the eggs, the age of the woman, and then you change into egg donation and you find out that the results are the same because the male has not been tested.
Yes, I 100% agree with you. I'm going to go into I'm going to ask one of the questions now. So this is a question that was sent earlier. This patient said, I have recurrent implantation failure. So we were talking about the fact that there's a bit of a grey area as to the difference between recurrent implantation failure and recurrent pregnancy loss, but because there is definitely some overlap. So she says she's had recurrent implantation failure and 2 chemical pregnancies with a double donor. I recently found out I have KIR type AA. I used compatible donor in my most recent cycles and still had a chemical pregnancy. She says I was on a kitchen sink immune protocol, which we had to look up and found out that meant that effectively they were given all the immunosuppressants, steroids, and so on. And she said, what else can I do? I'm currently down regulating and looking to having my next transfer. So what she doesn't say there is whether or not she had PGT-A. But do you want to answer? Do one of you want to answer that question for me?
Well, as we have already discussed, I can explain a bit this kind of a immunological issue. KIR type AA is a kind of immunological condition in which there is some interaction between some receptors in the surface of cells called natural killers and the surface of the embryo. The patients can be KIR A or B, which means that they are inhibitory or activatory, so they can inhibit or activate the immunology, and they interact with these antigens HLA-C1 or C2 that are in the surface of the embryo. Depending on certain combinations that could be also may seem to have some ethnic basis, there are bad relations, you know, and usually the worst here in Europe is when the patient's KIR AA, which is KIR A, and the embryo shows presents HLA-C2 more than the one that the recipient has, you know. It's a bit complicated to just summarize it in 5 minutes. The thing is that all the studies suggest that as long as you transfer one embryo, this should not cause any problem at all. It's a problem that appears only in egg donations, not IVF. All the studies have been published in egg donations, at least the ones I'm aware of, and only when you transfer 2 embryos. So if you carry a single embryo transfer, this should not explain any miscarriage, and neither should explain natural miscarriages, because natural conceptions, usually there is only 1 embryo there, you know. So I'm not sure if this has been the reason of having the
miscarriage.
It's probably there's something else. I mean, in this case, one of the suggestions I would say, I know that's still controversial, is checking the microbiome. You know, chronic recurrent endometritis may be a cause of recurrent miscarriages. Is asymptomatic. It basically depends on the percentage of lactobacilli in the endometrium. There are many tests available. At least here in Spain, we have EMAL is probably the best known. And then if you have a chronic symptomatic endometritis with antibiotics, probiotics, you may correct that, and well, it could help to reduce the risk of miscarriage.
Mm-hmm. And Harry, do you have something to add to that? The answer to that question?
Not really. I will say about the KIR HLA. I mean, first of all, here we are talking about a person that is having double donation. So when we are having double donation, we are having usually young donors, and at least in Greece, with double donation, we are not allowed by the national to do PGT-A. But here, I don't know if everything is happening through one egg donor or different egg donors, because sometimes even with egg donation and sperm donation, things can go unlucky and the embryos might not be good grading, and it might be much simpler than that. Also, we need to rule out other reasons of why we are having recurrent implantation failures or biochemical pregnancies, and some of these reasons is the microbiome, it's chronic endometritis that Raúl said before. A hysteroscopy, of course, needs to be done to rule out any other things. Mm-hmm. I mean, the evidence regarding tests like receptivity, ERA test, the ERMAP test, and all these things are getting less and less. But to be honest with you, when it is getting really, really unexplained, and in our unit we investigate everything, we do have some still position for this in our practice. Now, regarding the HLA-KIR antibodies, when we check, yes, transferring one embryo reduces the chances of something happening because the antigen inside is less. That's the thinking behind it. Of course, there are some other treatments as well that at least in our clinic we apply, and these treatments have to do with GCSF. I don't agree at all with this thing that you give all the medication. And, you know, when we are checking immunology in our unit, we do it very personalized. I mean, we do a special test, which is called the IMAP test. And we know what exactly is happening at the time of the embryo transfer after endometrial preparation and what is happening over there. Is it over suppression? Is it under suppression? And with these antibodies and antigens as well, it's specific medication that in some of the studies are recommended. For example, GCSF has given us some good results, but it's a medication that needs to be given with care. It needs to be given with people testing the full blood count and making sure that someone is not having raised white blood cells, and always with the help of an immunologist as well. The studies and the data behind it is though not conclusive, and we need to say that when we try to give these treatments.
Perfect.
I would suggest one more thing that sometimes is quite easy, and that depends on how the treatment has been done, because sometimes switching for an HRT to a natural cycle, when the patients still have natural periods, there are some studies. I mean, live birth tend to be the same in all the big studies comparing HRT to natural cycle. But well, we know that the hormones
especially with biochemical, that it says, you are right, yeah.
And then if the patient has natural cycles, consider natural cycle triggering the ovulation and transferring on day 5 after the natural ovulation is something that at least can reduce the prothrombotic effect of the hormones, and in some cases may help to reduce the risk of miscarriage.
No. Mm-hmm. Here it says that she has turned to down regulation, so maybe, I mean, in her clinic they are suspecting endometriosis or something like that. Maybe it's one of the reasons as well. Yeah.
But even if you suppress, you can down regulate for 2-3 months and then wait for the natural cycle and work with that, you know. Well, when we have problems with the HRT, in our clinic we work 7 days a week, so we have no issues and we can move onto natural cycles triggering the ovulation, and that's something that sometimes helps.
Mm-hmm. Okay, we'll move on to the next question. So the next question is, I have had 3 failed transfers. So we're going back to recurrent implantation failure. The first was a biochemical pregnancy, and the other The others failed to implant. All were high-graded PGT-A tested euploid embryos. My doctor suspects either endometriosis or adenomyosis as my uterus has a 90-degree tilt to the right. He wants to try 2 to 3 months of suppression with Depo-Lupron next transfer. Are there any other treatments or tests to consider? That is a good question. Harry, do you want to start with answering that question?
Yes. Okay, definitely with this history, we need to investigate and see why it is not working. Endometriosis could be one of the reasons. We have some genetic testing as well. If someone doesn't have a laparoscopy, which is the golden standard to find out if someone has endometriosis, we have some genetic testings that with quite a lot of accuracy can say if someone has a suspicion of endometriosis or not. And in this case, down regulation can help. Of course, if it is a very difficult embryo transfer, and it's a very tilted uterus or anything like that, we need also to make sure that the embryo transfer is happening properly. If there is endometriosis, many times it is associated with some inflammatory and immunological disorders as well. So, in our case, when we have in our practice clinic, when we have recurrent implantation failures and suspicion of endometriosis, we always check a bit more thoroughly about the immunology as well, and we might need to adjust the protocol with steroids, intralipids if needed. And after we check specifically about what is the issue. A chronic endometritis can also be a reason of recurrent implantation failures, and at the time of the hysteroscopy, they can check about that. And also because we are talking about PGT-A embryos, and we need to open up this thing, I think. It's very important every clinic to have a specific documentation of what it means, PGT-A embryos. Because euploid embryos, can be euploid embryos, usually less than 20% mosaicism rate. It plays a role as well, the grading of the embryo. It's not for sure that a euploid embryo with, from a grading embryo that it is like BC or BB, for example, will give you like 100% chances. 100% chances you don't have even with euploid embryos. So, we need to look at that a bit more thoroughly. And yes, if there is endometriosis, the down regulation might help.
Yeah, so you've mentioned immune, you've mentioned ruling out a structural problem, and you've mentioned the ruling out endometritis and microbiome testing. Dr. Raúl, would you add in anything else to that?
No. Really. Okay. In the end, in these cases, we have a limited amount of tools,
Yeah.
And something that I because there have been some studies that have suggested that as long as you transfer an euploid embryo, morphology is not so relevant. There is at least 2 big studies from the group of Rienzi in Rome that they had the similar implantation. The morphology is related to the percentage of the quality, genetic equality. So if you have an AA embryo, it's more likely to be normal than not a BC. Yes. But once you have an euploid embryos, at least the study, they were like 3,000 embryos transfer, something like that. They have very similar implantation rates. But in this case, it's probably chronic endometritis is what, and of course, adenomyosis have been related to recurrent miscarriages as well. So doing the suppression protocol should help.
And you just sort of briefly talked about ERA, and I would agree with you that it's becoming a little bit less common. Certainly, I don't counsel about ERA anymore unless patients are asking about it specifically. And I can't actually remember the last time I did an ERA test. But just for our listeners or viewers, can you just sort of outline why that is?
Well, there is a biopsy done after once the patients have started progesterone, basically to assess if the window of implantation is open or not. It was very promising, as it happens in assisted reproduction. Every time we have a new test, it's like it's going to solve all our problems. And then, unfortunately, much more of the time, we have to, from the reality that is almost useless, And I've done many. I mean, probably I've done more than 500, because was also started here in Spain from the EV group, and I started. The results were not and the same results that they have published. If I'm not wrong, in the last study they suggested that you need like 6 months to get a benefit, so 6 attempts, and that's clinically not really acceptable. And more especially when you can swift to a natural cycle, because the area has always been validated in hormone replacement therapies, but not in natural cycle. And according to our experience, we believe that in the natural cycle, the window of implantation is always open. If you have a patient that is menopausal and you need to do hormones and you are desperate, okay, you can try to do that. But we abandoned it like 5 years ago.
Mm-hmm. Yeah, Harry, would you say the same, that you don't really do ERA anymore?
We do it in exceptional cases, and the cases are the ones that Raúl said. I mean, when we can do as well a natural cycle, we prefer to go with a natural window, of course. But when we are talking with donations, with menopausal people, women that have checked everything and it is still not working, because we have couples like that, and also mainly our practice is from abroad. So, the natural cycles as well sometimes are not very easy to coordinate when people are coming from abroad, etc. In exceptional cases, we do it. But to be honest with you, I believe in the last years, much more in the immunology testing that we are doing, which is quite personalized, rather than the ERA test, which the data in the last ESRA as well, is getting lower and lower and lower.
Mm-hmm. Okay, we'll just move on to the next question. So one patient is asking how to avoid severe uterine cramping after transfer. Now, she hasn't mentioned the fact that, whether or not she's had recurrent implantation failure or miscarriage, but do either of you want to answer? So if I've had an embryo transfer and I've always experienced uterine cramps, what do you recommend?
Well, the best thing is progesterone, I suppose.
Yeah.
Progesterone is a muscle relaxant, so a Prolutex subcutaneous injection that has a very quick time of acting as well can be a solution, and that's it. As far as it regards not lifting weight, not walking and things like that, it doesn't have any evidence behind it. Always we suggest to take a bit of care after the embryo transfer, but that's it.
Okay. Here in Barcelona, there was a group checking that, because there were I remember if there was one study that suggested that if after the transfer you have some contractions of the uterus, if I'm not wrong, there was more than 5, that could reduce the implantation rate, And there's a group that have tried to, many years ago, I worked with indomethacin as a muscle relaxant after the transfer. Yeah, and we didn't have any benefit from that. The group that I know is now working with atosiban, which is the standard drug.
We used atosiban in a few cases as well.
The results have not been published yet, but as far as I know, there is no benefit. So it's very difficult, because it's very hard to measure how many contractions you have. You need to stay there with the scan, counting. It's very subjective. It's something that is there. One of the things that they are trying. But I don't know if this could have a really clinical relevation. If the transfers are if the cramps are right after the transfer and the transfer have been difficult, I would suggest muscle relaxant. It's true that sometimes the fact that you have high levels of progesterone may interact with the bowel, and these cramps may not be related to a gynecological issue. So one of the things that we usually have the patients, if they go to the toilet well, if they don't feel distended, because these cramps can be potentially caused by the bowels, not by the the ovaries that tend to be downregulated in the uterus.
So the next question's quite complex for me because it's something that I am not very familiar with. Patient asks, I have had several failed frozen transfers with donor eggs and donor sperm. It may be impossible to do some important immune tests such as HLA-DQQ matching, KIR-HLA-C mismatch, and LAD detection because donor samples are not available. Under this situation, can I take KIR typing and HLA-C typing? Will the results be informative? If not, how will any potential immunological problems be addressed? Do I need PGT-A testing to test the embryos if the egg donor is 25 years old?
I mean, and here in Spain, we can do PGT in a double donation if it's necessary. And as Harry has said, and the fact of using an egg donor does not guarantee that the embryos are going to be euploid. You know, that there are studies that suggest that up to 30% of the embryos that we can get in egg donation can be aneuploid, can have chromosomical issues. You know, and I've done PGT in some double donation tests, and I've got them. A very low 10% normal euploidy rate despite using egg donors, and these donors have been used later in life, and we've got an 80%. So there is also some variability, and you can just have bad luck, and PGT can be an answer. With regards to the KIR and HLA-C, well, it can be informative. As I've said, since this is a problem that can be solved by just carrying a single embryo transfer, it is not very common that can cause problems. But if you do the KIR and you are KIR B, then forget about it. It has no issue. If you are KIR A, well, then you can move forward and check in if you are HLA-C 11, 12, or 22. But if you do the KIR and the KIR is B or AB, which is BX also well, these are KIR types that are not related to any problem in Europe.
Perfect. So we don't have any other questions, but I'm just looking at my checklist. So we sort of talk. So I think genetics. I mean, we talk primarily about checking the genetics of embryos in order to reduce the risk of recurrent pregnancy loss. And I think we would all be in agreement with that. We talked about structural issues in terms of the role of hysteroscopy and ruling out any structural anomalies. We talked about endometritis and the role of Emma Alice, endometritis microbiome testing. We talked about ERA. We haven't talked so much about thrombophilia testing. So what's your feelings toward, what are your feelings towards that? And when do you test for that? And do you routinely test for that with every patient who's had recurrent pregnancy loss?
Harry?
We do test, yes, especially in younger women, that it's more unexplained. But when we have recurrent miscarriages, we need to check about thrombophilia. There is clear data that if someone is having antiphospholipid syndrome, will most probably miscarry. So, I mean, it's important to know about that for many reasons, for health reasons as well, but also about miscarriages, to cover with declotting injections, with aspirin, sometimes with steroids and Plaquenil as well, because antiphospholipid syndrome is an autoimmune condition, actually. We need to be very clear about the definition and when we characterize antiphospholipid syndrome, because it needs to have a clinical element, and it needs to have a laboratory element as well, because I have seen many times that you see a bit of raised antiphospholipid antibodies, and the title is very low, and people are characterized antiphospholipid without really being antiphospholipid. But it's not only that, there are some MTHFR, well-laden mutations as well that can cause issues, and you need to know it. And if you know it, the solution might be very easy, cover with declotting injections and find the solution. So yes, it's important to check about thrombophilia.
With regards to the thrombophilias, we have like two different levels. What I would like to point out is that there is one of the thrombophilias, not all the thrombophilias cause recurrent miscarriages, okay? And there is one that is very popular in the Mediterranean, which is the MTHFR, the metathetropholato reductase mutation. that it does. I mean, it should not be treated. I mean, we usually don't request it because up to 40% of the Mediterranean population can have it in heterozygosis.
Homozygous. When it is homozygous,
or homozygous. But even if it's homozygous and you check the homocysteine and the homocysteine levels are normal, you should do nothing about that. You don't have to add heparin or because of this mutation. The same happens with the PGT-A, the PGT-A1, which is a mutation of the fibrinogen. Okay, and there are other mutations. We have what we call an amplified panel in which we test for different mutations of the factor 5, not just Leiden. We test for Hong Kong, Cambridge, and we test also for mutations of the factor 12 and factor 13 in very, very specific cases. Okay, but if you don't know what to do, this sometimes can lead to heterozygosis and mutations in these factors that have been suggested that can increase the miscarriage rate. But the most important thing is that I see many patients that only have an heterozygosis of the MTHFR and they are put onto heparin just because of that. And if you use folinic acid, even if you have the homocystinemia, if you use folinic acid, this is going to be solved, and there is no reason to do that. And with regards to the antiphospholipid syndrome, well, our specialists sometimes talk about the hidden antiphospholipid syndrome, which are people that have all the clinical manifestations of the disease, but they have continuously negative antibodies. So we sometimes consider anticoagulant therapy just based on clinical evidence, not necessarily biochemical. When we have biochemical evidence, we usually tend to repeat the test like 3 months later, which is the 12-week later, to confirm whether they are still positive or not, because there are many false positives, especially low-level positives.
Mm-hmm.
But in some cases, when you have something with 5 miscarriages, probably I wouldn't consider the biochemical. I mean, I would add empirically aspirin and heparin just in case there is any antibody or any other mutation that can be causing the problem that could be relevant in a few years.
Yes, I would agree with you, and I also say that there may be an element of the unknown, something that we haven't explored or we don't have the knowledge for, and empirical clexane in that respect is fairly safe with a low risk of side effect profile.
It's also very important the dose of clexane, because we tend to work with 40 milligrams and that's it. And if the patient is 95 kilos, probably 40 milligrams would be
not
homeopathy.
Yeah.
Okay? So the therapeutic dose of the heparin, at least the one we use, is 1 milligram per kilo. So I've had patients that have been on 100 milligrams of clexane daily. And
that's actually what you're talking about, is a treatment dose of clexane rather than a prophylactic dose of clexane.
Exactly. So when we have patients that they are like 65, 70 kilos, we use 60 milligrams on a daily basis. And well, it could help, because we think that 40, when you have a clinical problem, not when you are trying because you have a thrombophilia in someone who has never had a miscarriage. We are talking about patients who have recurrent miscarriages, that they've had 4 or 5, despite transferring euploid embryos, and they still have miscarriages. We usually increase the dose of the heparin, and as I've said, I have patients with 80 milligrams or 100 milligrams a day.
And you don't have any experience of these patients having any bleeding or subchorionic hematomas, or no?
Well, these kind of doses are given by an hematologist, not by us. Okay. I probably can prescribe up to 60. Okay. And the idea behind that is that these patients may have an excess of course, of coagulation. So you are taking back them to normal levels. So we don't see in these very specific cases a higher risk of hematomas, the chorial issues, or bleedings once they are pregnant. In the patients who have been on these high doses are also patients that have had like thrombotic events before. So they had clinical conditions, thromboembolisms, pulmonary so they have potential. And then we use very high doses in these cases.
Okay. So then we sort of talked briefly about immune and DNA fragmentation. Is there anything else that you would like to add? Unfortunately, there aren't any other relevant questions in the chat.
Well, I mean, I think that the male factor cannot be forgotten. Okay, should be done. DNA fragmentation, either primary or secondary. When you identify risk factors like smoking, alcohol, too much coffee, certain spores, depending on the professional activity of the patients, varicocele infections, these are kind of problems that can increase the DNA fragmentation. And sometimes it's as easy as using antioxidants or removing the factors to get it back to normal levels. And this can help a lot, especially when you want to do PGT, because DNA fragmentation may not be the reason of the miscarriages, but if the DNA of the sperm is damaged, you are going to have fewer embryos of a worse quality. So in terms of optimizing the cycle to try to have as many embryos as possible of the best possible quality, fixing a DNA fragmentation can be a good thing to do.
Regarding the DNA fragmentation, I mean, we also check MRCOG test oxidation, because we had several examples that DNA fragmentation was not always associated to oxidation. And we got some sperms that were actually the opposite thing. There was reduction rather than oxidation. And when you start giving antioxidants in a person that has already a reductive sperm, you might make things worse rather than better. And we had situations, and especially this is quite often in men that take antidepressants. And there are some studies that with men that take antidepressants, the antioxidants might drop down to the opposite states, which is reductive, actually, sperma, which might be even worse at the time of the fertilization. As far as it regards the DNA fragmentation, if it is associated with oxidation, yes, antioxidants, lifestyle modifications, and we are trying as well some sperm selection techniques like Zymot or MAX.
Yeah. For example, with regards to DNA fragmentation, we carried out the COMET test, checking for single strand and double strand damage, because double strand damage tend to be worse, you know. But the idea is, if the patients want to invest any treatment that wants to improve the DNA fragmentation, should be done, according to our experience, at least for 2 months. Okay, because that's the time that you need to renew the whole bunch of sperm that is there in the epididymis waiting to be ejaculated. So you need to do it at least for 2 months before that. And if not, we use with the fertile chip or IMSI to select the sperm, and this also helps to reduce the impact.
But I suppose the question is, if you already have a genetically normal embryo, if you have a PGT-A euploid embryo, and the patient, let's assume, has had 5 blastocyst embryos, all euploid from one cycle, she's put back 2, and then they both haven't worked, then she's got 3 still left. Are you then going to go back and check DNA fragmentation, or are you going to want to encourage her to go ahead and use those 3 euploid embryos that are still in the air? So I feel like the conversation about DNA fragmentation probably needs to come a little bit before.
Exactly. Yeah.
So
we cannot forget also the statistics. I mean, I'm probably sure. I'm quite sure that you're probably aware that the last year was published a study in which it was a international study with that involved 124,000 couples, in which they were transferring euploid embryos in a woman that only had a scan done, nothing else, no hysteroscopy, no biopsies, just normal scan with triple line. And the results were that you need 3 euploid embryos to get a 93% live birth. And even in the group of that didn't get pregnant, they continue transferring. And when you reach 5 euploid embryos, you reach 98%.
Yeah.
So the study was very interesting, because the title was, "Does implantation failure really exist?" Because if you can obtain the right number of embryos, sometimes it's a matter of just keep trying.
I agree.
And you have to convince the patient.
I that all the time as well. Yeah, because I think we all want a euploid embryo to work. You know, we're all clinically invested in that euploid embryo giving us that pregnancy, but we have to remember that it's not 100%. And so if it's let's say 60 to 70%, then there's still a 30 to 40% of a chance that it's not going to work, and it's not inconceivable to think that you can get that multiple times. You know, so I agree with you, and I think going straight into multiple investigations looking for reasons for recurrent implantation failure or pregnancy loss may not always be the answer.
The patients,
it's true, but when you have I agree, but on the other hand, when you have a woman that she's more than 42, and you manage to achieve after many attempts the one embryo that you deployed, this is a very precious embryo. Then,
I know it's case by case, Harry. I know it's case by case. Yeah. You know,
one opportunity, you want to be sure that you are transferring that embryo in the best possible environment.
100%. 100%. We don't want to do anybody a disservice. You know, we all want to do the best for our patients. So it's about having knowledge and informing them accordingly. So perfect. Well, we don't have any further questions. Is there any
more?
Oh yes, there's one more. There's one more. I agree. I'm 39. I've had 3 miscarriages, 1 after a natural conception and 2 after frozen embryo transfers. None of the embryos were tested. Should I consider PGT-A now? Would it actually make a difference for someone like me? Are there any other tests I should do before another transfer?
I mean, I think that PGT is the right thing to do. And then if you do PGT and you have a lot of euploid embryos, well, then you can start looking for other factors. But the first thing is to guarantee that you can produce euploid embryos.
Yeah, because what would you quote as being the proportion of embryos which would be genetically abnormal at 39?
39 probably is going to be 30% of euploid embryos, something like that. 30,
so
between 30 and 35, so 1 in 3. So if she has had 1 natural and 2 frozen, well, of course, transferring an euploid embryo does not guarantee an ongoing pregnancy, unfortunately. But well, if you are doing IVF, I wouldn't do IVF without a PGT in your case. The problem with recurrent miscarriages is that you are changing the objective. When you're doing IVF because there is a tubal problem, you just want the patient to get pregnant. When you have recurrent miscarriages, the couples already got pregnant. You just need to make sure that the pregnancy is going to be an ongoing pregnancy. And then it makes sense to test every single embryo that you have.
Yeah. So would you be in agreement when she asks, are there any other tests that she should do before another transfer?
No. Before PGT, no.
PGT-A, no.
I would probably do IVF, PGT, and if all the embryos are abnormal, well, you have the answer. Then there is no reason to start, but you would have to decide if you want to try again, because also statistics sometimes are good. So if you have no embryos, this does not mean that the next cycle. I've got cases in which patients who have been through embryo banking, accumulating embryos, and then we test all the embryos at the end of the different stimulations. In one cycle, we have moved from 100% of normal embryos. The next month, 100% of abnormal embryos. So there is a biological variability. And I've got patients that were 42 that have tested 9 blastocysts, all abnormal, but because they have a good ovarian reserve, we have tried again, and in the second cycle, they have managed to get euploid embryos. So a single cycle sometimes is not enough.
I agree.
And in the end, it's a matter of, we know clearly that after 40, it's a matter of the number of eggs that you get to achieve the chromosomically normal embryo. The more you get, the more you increase your statistics, isn't it?
Exactly. There is a very interesting study checking the percentage of the embryos, of the euploid embryos, and the thing was that the patients that managed to produce 10 blastocysts did not have better percentage of euploid embryos. The percentage of the aneuploid embryos keep very similar regardless of the number of embryos tested, suggesting that the ovarian reserve has nothing to do with the oocyte quality. But of course, a 10% of 10 is more than a 10% of 1. So the fact of aiming at having as many eggs as you can and getting as many embryos is going to increase your statistics just because of the number, not because the embryos are going to be better, which sometimes can happen,
Yeah.
but it's more related to quantity rather than quantity.
Well, thank you very much. I must admit that it's very refreshing to know that in spite of living in 3 completely different countries, we all speak the same language of reproductive health. So that's fantastic. So I'm going to wrap it up. Does anyone have anything else to add? No? Okay, well, thank you very much for joining today. Thank you. Thanks, Harry. Thank you, Raúl. I wish you all a very happy Christmas and a very happy New Year. And we look forward to joining again, having an audience again back in the new year. So I hope everyone has a lovely break. And thank you again for joining today.
You're very welcome. Thank you very much. Many pregnancies for 2026.
100%. Yeah. Thank you.
Exactly.
Bye.